My name is Casey Vasta. I'm a palliative care physician assistant with UT Health. I practice palliative care medicine at Memorial Hermann in the Texas Medical Center. This project is funded by a grant from the Health Resources and Services Administration of the Department of Health and Human Services. The grant was initially funded in 2007 with renewed funding for 5 years beginning in 2010. Today we're going to talk about assessing pain in older adults. To do that, first we'll describe the current environment and prevalence of pain in aging adults. Then we'll review the effect of cognitive impairment on pain assessment and delivery. We'll discuss the barriers to adequate pain treatment. We'll discuss the implications of untreated pain. We'll review various pain assessment techniques and how to recognize pain behaviors. And we'll finish with a brief overview of pain management principles and therapies. Aging does not equal pain. Yet many people feel pain is inevitable and a normal part of aging. A study of patients with osteoarthritis found that patients greater than 70 years old thought people should expect pain as a normal part of aging. However, several studies have shown that musculoskeletal pain generally declines with advancing age, and a 2010 study found patients in their last 2 years of life were having less pain as the individual aged. So we know pain is not something we should expect or tolerate as we age, but just how many people are suffering from pain symptoms in the older adult population? Around 60% in the community and 80% in nursing homes are experiencing pain. These are high numbers and show that focusing on pain assessment and management in this population will positively affect a large number of individuals. There is a general lack of knowledge and action regarding assessment and treatment of pain in older patients. Here we will look at some of the reasons medication often never reaches a geriatric patient in pain. Like we said before, many people believe pain and aging go hand in hand. Some patients withhold pain reports to avoid hospitalization and invasive testing. Others fear learning the source of their pain. Many people have false beliefs and phobias about opioid use, including prescribers. What's more, a 2012 study found that 16% of physicians estimated 1 in 4 older patients receiving chronic opioid therapy become addicted. The actual risk is far lower and is only around 3%. According to one retrospective cohort study of older patients who had been recently started on opioid medication for the treatment of chronic pain. Prescribers also fear regulatory backlash or disciplinary action for prescribing controlled substances routinely. Another barrier is lack of clinician and nursing training on recognition of pain behaviors. We'll touch on this more later. But failure by caregivers to recognize these behaviors presents one of the biggest barriers to adequate pain medication delivery. And a related topic, cognitive impairment interferes to a very large degree with pain management and assessment. So what is cognitive impairment and how does it affect pain assessment? Cognitive impairment is defined as difficulty remembering, learning new things, concentrating, or making decisions that affect everyday life. Age is the greatest risk factor. 5.1 million Americans greater than 65 years of age have Alzheimer's dementia, the most common type of dementia. And greater than 50% of elderly people living in facilities have dementia. Many studies show that as cognitive impairment increases, less documentation and less pain medication is given. The studies by Felt and Morrison, as seen below, were developed in acute care settings, while the rest occurred in nursing homes. This graph represents how cognitive impairment affects a patient's ability to receive pain medication. This study was conducted in a nursing home and found that only 56% of patients with reduced cognitive function received pain medication, as compared to 80% of patients with intact cognition with similar pain complaints and similar characteristics. What happens when we don't treat pain? Patients develop depression, anxiety, falls, malnutrition, cognitive impairment, and physical debility. They might suffer from decreased appetite, impaired sleep, declines in socialization, and an overall reduced quality of life. It's also important to note that depression and pain are many times closely related, and the presence of one often worsens the severity of the other. Adequate pain treatment starts with thorough assessment. Assessment should start with a full past medical history, with special attention to all pain medications tried, past and present, including natural remedies, tobacco, alcohol, and illicit drug use. Next, a physical exam should include a complete evaluation of all major systems, with special focus on the neuromuscular and musculoskeletal systems. A functional status assessment should occur to establish a benchmark for progression or deterioration in pain management. A functional status assessment should occur to establish a benchmark for progression or deterioration in pain management. Functional abilities may be assessed with numerous techniques, such as the CATS Activities of Daily Living or the Lawton Independent Activities of Daily Living scale. A simpler method is to ask, how many days over the last 6 months have you been unable to do what you want to do because of your pain? This succinctly identifies the effect of pain on the patient's overall well-being and status of health. Psychosocial factors and the total pain experience should be addressed, especially in the setting of depression or anxiety. It is essential to recognize the presence of depression and treat it, because failing to do so will result in ineffective pain management. Also, activities of daily living will be significantly limited in the setting of untreated pain, further perpetuating the pain and depression cycle. In 2006, Her et al. Published a guide to the assessment of pain in nonverbal patients, identifying the patient report, pain behaviors, possible causes, surrogate report, and empiric therapy as the key elements of a high-quality pain assessment. We will explore it here in the broader sense of pain assessment, irregardless of cognitive impairment. With the exception of the patient report, which should always be attempted first, these techniques may be used in any order. Self-report is the gold standard and most reliable. A 2009 study demonstrated pain estimates by nurses did not equate to the self-report measurements that patients provided. Even with mild to moderate cognitive impairment, attempts should be made to obtain a self-report of pain. If they have cognitive impairment, providing questioning about present pain and then giving repeated instruction and adequate response time will aid in the effort of self-report. Older adults often deny pain, so you may need to rephrase and ask, do you hurt anywhere? Are you uncomfortable? We've talked about the pain and depression link before. Depression can blunt symptoms of pain or can exacerbate the perception or severity of pain. It's important to look at pain in the context of the individual's experience. Pain may represent loss, threat, challenge. It might mean losing their independence or even loss of life. It helps to evaluate what their pain experience is, as well as their coping resources. Do they believe their pain can be controlled? What pain management preferences do they have? What economic issues related to pain treatment concern them? How is it affecting their overall quality of life? The patient report can be defined by the pain history. Here are shown the various elements to a pain history. The patients should be asked about location, including radiation. You might instruct them to point to the area that hurts, or it might be helpful for older adults to use pain maps or drawings of the human body where they can indicate the location of pain. This method has been shown to be valid when used with cognitively impaired patients in nursing homes. Intensity is most commonly obtained through use of a numerical rating scale, which we'll talk more about later, or it may be easier for patients to say mild to moderate to severe. Pattern questions include, when did it start? How long does it last? How often does it occur? The character of the pain should be asked, and common prompts include dull, aching, burning, sharp, stabbing, or gnawing. Patients may often say, I just can't describe it. Is the duration of pain constant, episodic, waxing and waning? What is the onset? When did this start? Is it a recent or a chronic problem? Associated factors include asking what alleviates the pain and what exacerbates it. Ask what techniques have been tried or what medications have worked or not worked. It's always important to think of the common conditions that could be the source of pain. Most common in our aging population includes pneumonia, urinary tract infection, skin infections, dental problems, fractures, positioning problems, bladder distension. Also common are kidney stones, ulcers, gout, peripheral arterial disease, constipation, and peripheral neuropathy. Getting input from family members, parents, caregivers, and friends is another great way to assess pain, especially when the patient is limited in their ability to inform you. These individuals may be able to notice subtle, less obvious changes in behavior that are indicative of pain. Particularly in nonverbal patients, physicians, nurses, and aides may all rate pain in one way, and it might also vary from inpatient to outpatient setting and from acute care to long-term care facility settings. By obtaining history from family members, it helps close the gap on these discrepancies and leads to a more accurate pain assessment. Starting medication and reassessing for responsiveness is another method of assessment. If they have likely underlying causes, you could treat for pain and watch the response either in pain behaviors or in their patient report and numerical ratings. You titrate upwards based on pain behavior response or dose-limiting adverse effects. When taking a pain history from patients, we said before, it's important to quantify the severity. We're going to discuss a few more of the common methods here. It's important to note that regardless of the scale used, the same one must be used every time pain is assessed because the scales are not interchangeable. The numerical rating scale is the most common scale in use. It is easy to use and many people are familiar with it. The clinician asks the patient to rate their pain on a scale of 0 to 10, where 0 equals no pain and 10 equals the worst pain imaginable. While this is both a reliable and valid pain scale, a substantial portion of older adults with and without cognitive impairment have difficulty responding to this scale. Here is the verbal descriptor scale. This verbal descriptor scale is both a reliable and valid scale, but requires that the older adult be more articulate. However, 2 recent studies demonstrated that this was the preferred scale among older patients. Another study showed that of 89 cognitively intact older adults, 100% were able to complete this scale, and of those with cognitive impairment, 73% were still able to complete this scale. The pain thermometer is a variation of the verbal descriptor scale that is modified to vertical representation. This is the preferred scale for patients with moderate to severe cognitive deficits or those who struggle with abstract thinking or communication. The pain thermometer asks patients to rate their pain no pain, mild pain, moderate pain, severe pain, extreme pain, or pain as bad as it could be. This is the FACES pain scale on top and the Wong-Baker FACES pain rating scale on the bottom. The Wong-Baker was originally developed for use with children. A 2000 study with a mix of cognitively impaired and cognitively intact patients demonstrated that this scale appeared to measure a broader definition of pain that included affective and sensory components. It's most beneficial for use with patients demonstrating low education or literacy levels, dyslexia, or other learning disabilities. Here we'll talk about special techniques and scales for cognitive impairment. There are over a dozen different types of scales specifically designed for patients with cognitive impairment. We'll discuss 2 here. PAINAD, the Pain Assessment in Advanced Dementia, and Pain Behaviors. PAINAD is a simple, valid, and reliable instrument for the measurement of pain in non-communicative patients. The total score ranges from 0 to 10 points. A possible interpretation of scores is 1 to 3 for mild pain, 4 to 6 for moderate pain, 7 to 10 for severe pain. It has been evaluated in numerous settings, satisfies credentialing auditors, and is clinically usable. The 5 factors assessed are breathing, negative vocalization, facial expression, body language, and consolability. A similar method of assessment for pain in non-communicative patients is to recognize pain behaviors and treat empirically. Facial expressions you're looking for include a slight frown, a sad, frightened face, or perhaps grimacing, wrinkled forehead, or tightened eyes. Verbalizations like sighing, moaning, groaning, calling out, or verbal abusiveness might indicate pain. Body movements suggesting pain include rigid, tense body posture, increased pacing, and restricted movement. Changes in interactions that indicate pain are aggression, resistance to care, decreased socialization, and socially inappropriate reactions. A change in activities, such as refusing food, sleep changes, and increased wandering, are reason to suspect pain is present. And lastly, noticing mental status changes, like crying, increased confusion, or irritability, point to pain as a possible cause. We've talked about the importance of pain assessment and various assessment techniques, and now we'll briefly go over the principles of pain management. Physical pain is controlled by non-pharmacologic and pharmacologic treatments. Pharmacologic treatments are further broken down into non-opioids, opioids, and adjuvants. Combining both pharmacologic and non-pharmacologic methods of pain assessment often leads to enhanced pain relief. One study found that Tylenol, heat and cold modalities, regular exercise, and prayer were the most common forms of pain management strategies. Non-pharmacologic treatments include exercise, heat and cold modalities, relaxation, and prayer. Vigorous exercise that aggravates pain should be avoided, but exercise can help patients retain balance, stamina, and strength. Yoga is the most effective form of pain-reducing exercise available in our older patients. For heat and cold modalities, typically you'll want to apply cold packs when the source of pain is more acute and related to sprain, strain, or bruising. Heat is best utilized for sore muscles and injuries greater than 48 hours. Both modalities work to reduce inflammation. Relaxation can take many forms, including warm baths, aromatherapy, massage, and acupuncture. Additionally, laughter has been found to promote feelings of positivity while also allowing the individual to take deeper breaths, reduce blood pressure, and release endorphins. In the pharmacologic treatment category, non-opioid medications such as acetaminophen, aspirin, and ibuprofen are available. Tylenol is the #1 recommended non-opioid analgesic recommended by the American Geriatric Society. Staying below 4 grams daily is recommended as well. Ibuprofen and other non-steroidal anti-inflammatory medications pose a much greater risk, as they can cause gastrointestinal bleed and kidney failure and should be avoided in our older adults. Opioids work centrally in the brain to provide high-quality and effective analgesic relief. The American Geriatric Society, the American Pain Society, and the American Academy of Pain Medicine recommend that all patients with moderate to severe pain causing functional impairments and diminished quality of life, be considered for opioid therapy. Patients should be carefully selected and monitored, with dose adjustments and frequent reassessments for adequate analgesic effect to be determined. A general principle is to start low and go slow. Adjuvants are drugs that include antidepressants, anticonvulsants, and other agents that, while developed for one indication, were found to have analgesic effects. These are especially useful in neuropathic pain syndromes and augment other agents being administered. The pain ladder, or analgesic ladder, was originated by the World Health Organization to describe its guideline for the use of drugs in the management of pain. It was originally applied to the management of cancer pain, but it is now widely used by medical professionals for the management of all types of pain. Step 1 is to start at a non-opioid, with or without an adjuvant. If pain is not controlled, escalation to a mild opioid is advised. If pain continues to persist, A strong opioid should be started and titrated until adequate pain relief is achieved. To summarize, pain is not a normal part of aging. Cognitive impairment significantly impacts pain assessment and treatment. Recognizing pain behaviors is essential. We talked about how many barriers exist to successful pain treatment. We talked about the numerous ways to assess for pain, but above all else, it's just most important to assess in the first place. And high-quality pain management approaches pain from multiple angles and uses a stepwise approach.